present the next talk by Professor Khaled Ismat, recent updates of role of MRI in brainstem lesion.
First of all, thank you all for being here with us now that late afternoon. I'd like to thank the organizational committee for the Society of Radiology in Egypt for the wonderful and successful organization of this conference. Professor Tarek, Professor Haniod here, and now Professor Ahmed with us, so I thank them very much. I started my journey with MRI 30 years ago. It was at the United States at the Yale University MRI Center, and from that time till now, I'm almost fascinated with the brainstem. I always look at the brainstem at the most important miracle of God in the human body. In this brainstem, in this small structure, everything is there. Everything coming from the brain goes down through the brainstem. Everything sensory goes the other way, controlling many vital centers of the body. So I always look at that part with most respect and astonishing pattern. How come this small part controls the whole body? That's why every now and then I collect lectures, I give lectures about the brainstem and the role of MRI to highlight more how we can help the clinician, not only in saying that there is a problem in the brainstem. Now we have also to tell him where is the problem and what it can affect. So let's go quickly to entertain some of the parts and disease. Most of the pictures today is coming very recently from a paper which was nicely published from the Department of Neuroradiology at NHS in United Kingdom. They collect very nice pictures of the brainstem lesions. As you see here, this is the small structure called midbrain, which was the superior part of the brainstem. On the right side, you can see the picture in the MRI you always see. Can you believe that this small part have all these structures in it? They have the trigeminal meniscus, which is here. We have the red nucleus here, substantia nigra, which is here. We have the cerebral peduncles with the corticospinal and corticobulbar tracts here. And in black here in the MRI. We have the oculomotor nucleus and the oculomotor nerve coming from the medial part of the midbrain here. So this small structure you people are seeing or reporting on MRI have all of these structures inside. Cerebral peduncle is very important part of the midbrain as well as oculomotor nucleus, and we're going to see how. Again, this is the red nucleus and oculomotor nerve area. This patient usually comes with hemiparesis, contralateral hemiplegia or hemiparesis. He comes with ipsilateral oculomotor nerve palsy. When I found a lesion in this part of the midbrain, think about Weber syndrome. And you can guide the clinician for that. If you had a lesion here, whether infarction, MS, ischemia, or whatever. Another part here, just 1 second. Last one. Last one. تعال. أنا طلبت طريقة معينة إن يكون موجود فيها. لا مش دي. الطريقة التانية اللي قلت لك هناك. تمام. أوكي. I'm sorry for that. Okay. تمام. All right, we are on the right track now. So if we found this area involved, so it is involving the corticospinal tracts and the oculomotor nerve pathway, this is the presentation of the Weber syndrome. Another way, if we go more medially and get a lesion here, which affect more the red nucleus and the oculomotor nerve, the patient usually come with ipsilateral also oculomotor nerve palsy, and he come with crossed hemiataxia, incoordination, and chorea. This is what they call it the Bendix syndrome. The patient here, it's more localized to the medial aspect of the midbrain. The patient usually come with incoordination, contralateral upper and lower cerebellar hemiataxia, and of course, oculomotor nerve palsy ipsilateral. This is called infarction for the dorsomedial part. It's more dorsomedial here. It's this infarction, they call it cloud syndrome. Another case, the patient comes here with upward gaze palsy, pupillary light near dissociation, and convergent retraction nystagmus. The clinical picture which I'm talking about is very important for diagnosis, because when the patient comes with this clinical picture, and you have to insist that the neuro people or the neuroclinicians, they send you the proper detailed clinical history, not just headache, not just very simple words of clinical history. No, you have to know the details so it can help you more. And I tell you why in the end. This patient usually have here is the tectal plate, more compression on the tectal plate here. The lesion here is the germinoma. This germinoma, enhancing germinoma, has make compression of the tectal plate, and this case called Paris-Node syndrome. If you go more down for the pons, which is also very interesting part of the brainstem, you can, this pons, as you see it here, you cannot imagine all these structures is inside the pons. All of these structures, like the nuclei of the most important cranial nerves, the lateral lemniscus, the medial lemniscus, and the tracts, the corticospinal tracts also in the anterior aspect, and in the facial colliculus in the dorsal aspect. All these important structures, you can see it on the middle. Also, if you go more details to the basis pontis, which is still more lower down here at the level of the internal auditory canal, you can find all of these structures inside. And for small lesions that affect this part, you can get a localized clinical symptoms or clinical history. This patient coming with a lot of things. This patient, when you have affected this yellow area, when it is affected in the pons, the patient here comes with hemiparesis, contralateral hemiplegia or hemiparesis. He comes with impairment, ipsilateral impairment of pain and temperature sensation, limb ataxia, facial paralysis, hearing loss, vertigo, and nystagmus. All of that, if you found an infarction or a lesion here, pathology in this area. This is what they call it, the Marie-Foix syndrome. Never mind about the name of the syndromes, you can get it easily from the literature, but at least you can correlate the symptoms of the patient with the area affected on the midbrain or the pons or the medulla. Another patient here, he came with contralateral hemiparesis. This blue area is the area affected, as you see it here. This area is affected. In the diffusion, it's well seen as diffusion restricted part here, and also in the flare, in the coronal flare and axial flare, you can see. This infarction, which comes in this area, the patient will actually will come with contralateral hemiparesis, hemiplegia, hemisensory loss, ipsilateral facial nerve palsy, conjugate gaze palsy, inability to look at the side of the lesion. This all clinical detail, you can find it only for this lesion, which is called foveal syndrome. Another infarction, very well seen here in the basis pontis. It's completely most of the pons, but only on the medial aspect or the paramedian aspect. The patient here come with some of the symptoms that I told you, but he spared the oculomotor nerve and the oculomotor tract pathway. This is called locked-in syndrome. Another case, if this lesion also only here affected, you found this patient coming with lateral gaze weakness, ipsilateral lateral rectus paresis, contralateral hemiplegia. This is what they call ventral pontine syndrome. To go quickly with the time, this is the affected area. Every part affected in the bones, you will find, if you look back at the map of your clinical map, you will find why the patient is suffering from that part. Another lesion, the patient in this part, he's suffering from horizontal conjugate gaze palsy, loss of taste sensation. You find the lesion is small part, very small part here, as you see it in the diffusion image. And sometimes it passed, not detected. So if you get loss of taste sensation, beside corona and what we heard about the corona, look at this part very carefully, don't miss it, and look at this area, and you will see that the left facial colliculus is affected by lesion. And the patient mainly will come with more than one thing: diplopia, horizontal conjugate gaze palsy, hyperacusis, but the most important is that he will have loss of taste sensation in the anterior two-thirds of the tongue. If you're going down to the medulla now, medulla oblongata, very small structure, but also a lot of structures inside. As you see, all of these structures, can you imagine? Just I give you a few seconds that you look at it, and look at all of these structures passing through the brainstem, passing through the medulla oblongata. It's unbelievable miracle, or God miracle on the human body. Again, very small lesion, you can detect it here in the diffusion-weighted images, here in the posterior aspect of the medulla. This patient usually comes with a lot of things. Only this small lesion, and the patient comes with what? He comes with vertigo, he comes with falling toward the side of the lesion, diplopia, multidirectional nystagmus, ipsilateral Horner syndrome, hiccup, contralateral body loss of pain and temperature sensation, hoarseness, dysphonia, dysphagia, dysarthria, and decreased gag reflex. All of this from just this small pathology. This is called Wallenberg syndrome. I'm sure you heard about it. Again, if this part of the medulla, which is the ventral medial part of the medulla, affected by any lesion, the patient will come with contralateral weakness, hemisensory deficit, and ipsilateral hypoglossal palsy. This is what they call Dejournay syndrome. Another patient, if you get the whole medulla affected on that side, this patient will come with ipsilateral cerebellar ataxia. He will come sensory deficit of the face, Horner syndrome, contralateral hemiplegia or hemianesthesia. This is what they call it Babinski-Nagunet syndrome. I'm not saying the name of syndromes to make you confused, but it's already in the literature. So if you put it in your report, that will be much better, more professional, if you go more and put the name of the syndrome. But if not, it's okay. This another patient show right inferior medullar cavernoma. It's small cavernoma, as you see it here, on the right aspect, the right posterior aspect. The patient usually here come with ipsilateral cerebellar ataxia. He comes with sensory deficit of the face, Horner syndrome also, contralateral hemiplegia. This is what we call it Babinski-Nagunet syndrome. Another lesion, if you come this triangle, they call it hypertrophic olivary degeneration, and usually the patient come here with palatal myoclonus. He come with cerebellar or brainstem dysfunction. It affects this triangle, which is like Bermuda Triangle we're talking about in the history. Now this triangle of Guillain and Mollaret, if affected any area of this inside the triangle, the patient usually will come with the symptoms with palatal myoclonus and with brainstem dysfunction. Another patient for the same hypertrophic also olivary degeneration. There is spontaneous bleeding here at this aspect, and the patient comes with the same symptoms. This patient, he came with unilateral or bilateral. He can come with unilateral or bilateral facial. It's very difficult to see inside the Meckel's cave. But if you got high resolution MRI, like 3 Tesla or very good machine 1.5, you can go through the Meckel cave and see what's inside and what is not inside. If you cannot see the facial and the abducent, That syndrome is called Mobius syndrome. Another case, I think you can see a lot of this case. We find in the thalamus and the medial aspect of the thalamus, bilateral symmetrical lesion. But here, if you go down, you can see it here in the midbrain and down here also posteriorly in the medulla. These bilateral symmetrical lesions. The patient here comes with a conscious problem, ataxia, ocular dysfunction. This is typical of Wernicke encephalopathy or encephalopathy. I'm sorry. Okay, I'm almost finished. This case was in our hostel last week, and it already missed by one of our primary reporters. She missed this lesion at the lowest aspect of the medulla. I brought this for everybody to be sure when you look at the diffusion, please look it from down, from the bottom to the top. Don't underestimate the medulla, and you look at the you look on the cerebral cortex, you look at the basal ganglia, and you look upstairs. No, start with the medulla, look carefully for it. This patient came with dysphagia, and she has nothing else, and this explained because it was in the territory of the inferior olivary nucleus and spinothalamic tracts. This was done in our hospital. Lastly, it's away from our role today. This is the last slide. I was following the radiology, the Royal College of Radiology London conference last month. It was a very nice online conference. And one of the posters there, they put the brush sign. This is the brush sign. You can see now many centers are doing the SWI for the brain routine with the stroke protocol, and some of the people say why we need it, maybe on hemorrhage or somebody. No, it's also, if you see this brush sign, like brush, it's one of the indications of infarction. Thank you very much.
Thank you, Dr. Khaled, for the very nice presentation and educational for all of us. I think we, for the sake of time, will keep questions to the end, or you can have them with the speakers privately or during the dinner or lunch. It's my privilege to present the next speaker, Professor Dr. Hisham Sheikh.